Discerning a peripheral vestibular pathology from central vestibular pathology. Observation of nystagmus is a useful tool for assisting and determining a diagnosis of a CNS pathology. Nystagmus from a cerebellar lesion may be in a pure vertical direction. Nystagmus may not have a slow component and the eyes therefore oscillate at equal speeds, which is called pendular nystagmus. Pendular nystagmus is often indicative of a congenital disorder such as absence of central vision. Another clue in discerning a central versus peripheral vestibular pathology is the recovery time. Unlike peripheral vestibular pathologies nystagmus, the nystagmus from central vestibular pathology often never resolves.
So what is the difference between central vestibular pathology and peripheral vestibular pathology? So first, in central, the ataxia is often severe, while in peripheral, the ataxia is only mild. In central, there is abnormal smooth pursuit and abnormal saccadic eye movements, while in peripheral, there is normal saccadic eye movements and smooth pursuit. Central vestibular pathology symptoms include acute vertigo, not usually suppressed by visual fixation, while in peripheral, symptoms of acute vertigo is usually suppressed by visual fixation. In central vestibular pathology, symptoms of acute vertigo usually is intense, more than central vestibular pathology. In central vestibular also, there is pendular nystagmus, while in peripheral vestibular pathology, nystagmus will incorporate slow and fast phases. In central, there is pure persistent vertical nystagmus, which persists regardless of positional testing. There is persistent downbeat nystagmus in Hall-Pike test and in anterior canal BPV. In peripheral, there is spontaneous horizontal nystagmus, which usually resolves within 7 days in a patient with UVH. This is the summary of what I said.
Patients with lesions of the vestibular nuclei can present with vertigo, nystagmus, and disequilibrium. While patients with lesions above the level of the vestibular nuclei will present with head tilt, visual perceptual difficulties, oculomotor signs, and lateral pulsion. Lateral pulsion meaning the person's tendency to fall to one side. Classifying central vestibular symptoms require an establishment of perceptual, oculomotor, and postural signs. The most sensitive signs of a unilateral brainstem infarct are the tilt of the patient's SVV and ocular torsion. Ocular torsion refers to the superior pole of the eyes moving together in a roll direction, as you can see in this video. To classify complete ocular tilt reaction, the patient should have ocular torsion combined with head tilting and skew deviation. Skew deviation or the superior displacement of one eye.
Now, I will present the red flags that the physical therapist should be aware of in case of a central vestibular pathology. First, a horizontal or vertical diplopia lasting 2 weeks after the onset of the signs and symptoms thought to be due to IUVH. Second, you should note that the anterior canal capulophiasis should be ruled out. Third, spontaneous upbeating nystagmus. You should be aware of that, though it is rare. Then last, positive test for skew deviation. If the red flags are present, an individual is recommended to consult a neurologist.